Yesterday I was talking about the PD-L1 IHC assay versus tumor mutation burden. And with PD-L1 we have several problems to face. One is the major problem is, of course, that each drug has their own assay. And the assays differ both in terms of antibodies, in terms of staining procedure platforms, and furthermore, in the clinical trials, there are different cutoffs used for what they called positive or negative results. So this is confusing. So the ISLC, the International Association for Studies of Lung Cancer, has taken on board what we call the blueprint projects, which is to compare the analytical performance of each assay. And we did that first in phase 1 in a smaller study. And it showed that 3 of the assays, DAGOS 28.8, 22C3, and SP263 from Ventana had quite a similar analytical performance in terms of tumor cell expression of PD-L1, while SP142 from Ventana, which is used in the studies with atezolizumab from Genentech Roche, has been an outlier, was found to be an outlier with staining fewer tumor cells. In terms of immune cells, there was a wide variation among all assays. Now, we published phase 1, and now we have presented at the World Lung a few months ago the phase 2, which is a much larger study. And phase 2 verified the results from phase 1, that the 3 assays are performing very similar in terms of tumor cell expression, while SP142 stained fewer cells, and 7310, which we added to the study, and 7310 is related to avelumab. This assay stained a little bit more tumor cells than the others. So what is the conclusion of this? The conclusion of this is that we think there can be harmonization possible with the 3 assays and interchangeability. Now, why are we a little bit cautious? Because the cutoff values, of course, if the cutoff values varies, then the difference between the assays will play out most likely. But if the cutoff value is the same, we probably believe that the 3 assays can be interchangeable. We are now doing a next step in the blueprint project, and that is studying a larger sample set. We are comparing large samples with smaller samples, with cytology, and we are looking into the performance of all 5 assays. So that is the story about PD-L1. We know that in most studies, PD-L1 positive patients do better than PD-L1 negative patients. But the fact that some PD-L1 negative patients can benefit from immunotherapy makes us a little bit concerned about the role of the biomarker.